Hello, everyone, and welcome to our Dr. M. Alfred Haynes lecture for the month of October. We hope you are all having a great week. My name is Kiosha Partlow. I'm the director of the Urban Health Institute. Let me just do a quick run through to go through our agenda today. We have an amazing talk in store for you today. We're going to, following my introduction of our speaker, we're going to go into hearing his talk that he's prepared for us. In addition, we will ensure that you will have time to ask any questions. We will provide time for that toward the end of our guest's today's talk. And feel free to use the chat box. If there are any questions that are coming up as you're hearing the talk, feel free to use the chat box in Zoom, and I will go through those questions at the very end, and then we'll end with closing remarks. So really quickly, our Haynes series is hosted by our Urban Health Institute, and our Urban Health Institute is Charles R. Drew University of Medicine and Sciences Research Endowment. Our focus is in front of you in terms of really focusing on building the university's research capacity, particularly focused on improving health and wellness for underserved, under-resourced communities. Our Dr. M. Alfred Haynes lecture series has been going on for, we're quickly embarking on our 4th year now. And the focus is really to elevate awareness and engage discussion around health disparities, social justice, health equity, social determinants of health. And it's in honor of former Dean, President Emeritus, Dr. M. Alfred Haynes. And it is my pleasure to introduce Dr. Javier Rodriguez. Dr. Rodriguez is currently the Mary Topelt Nicolai and George S. Blair Assistant Professor of Politics and Government, and also the co-director of the Inequality and Policy Research Center and the Institute for Democratic Renewal at Claremont Graduate University. He's published numerous articles in high impact journals. He's a leading scholar in advancing political epidemiology approach to health inequality in the United States. And this is so timely to have him here today. His area highlights political causes and consequences of issues related to US infant mortality, premature death among poor and working class individuals. Ladies and gentlemen, Dr. Rodriguez is going to be talking to us about politics and mortality in the United States. Please join me in providing a warm welcome to Dr. Javier Rodriguez.
Thank you very much, Kiosha, for your generous introduction. I'm going to be sharing now my screen. Do you see my screen?
Yes.
Okay, thank you very much for having me. Okay, so it's an honor. You have no idea for how long we have been preparing this talk. And Carolyn and Kiosha have been great to me. Thank you very much for your patience. I have a long presentation, so let's not waste more time and get the ball rolling. I'm going to be talking about politics and health. And to talk about politics and health should not be necessarily to become political about health, even though it has been increasingly political, as you may have noticed during the pandemic. So let me give you just an appetizer to get the presentation going on what's the problem. So for example, the United States spent about $3.6 trillion in 2018. That's about 18% of GDP, more than $11,000 per person on healthcare. That ranks the United States as number one in the world for per capita healthcare spending. That's more than double than the average of other OECD nations. Every year, we have about 2.8 million deaths in the United States. The great majority are related to health. So it's not related to war or homicides or accidents. The great majority are related to health. However, our outcomes, our health outcomes are poorer than all OECD nations and many underdeveloped nations. So for example, you may already know the life expectancy in the United States recently declined for 3 consecutive years between 2014 and 2017. And the United States has become an outlier in many ways. We don't have to go very far. Just look at what has been happening during the COVID-19 pandemic. So let me tell you a little bit more about how to connect these ideas on politics and health. I call it the politics hypothesis. So to give you an introduction, let me give you some observations. Let's start with the observation that life expectancy in the US falls behind and infant mortality rates exceed those in many other countries, suggesting that maybe political factors may contribute to these differences. We know that environmental and social, and every time we talk about the social determinants of health, politics is social. So these are broadly signaled as the major contributors to health status. Political authorities, for example, the presidential coalition, party coalition in state legislatures, do not control health per se, but they shape health policy, including interventions that affect the social determinants of health. Just think about healthcare services, access, macroeconomics. We also know that political ideology informs health policy. Nowadays, maybe the most polarizing issue between the parties in the United States. The US president is known because of his huge political power. It's also the center of the media. And the many legislative, regulatory, and budgetary powers that he uses, it has a primary role on promoting and enacting the party that the president represents. So just to give you an appetizer, these type of ideas can propose a research question like, is the political party that is in power associated with an important, objective, and sensitive measure of population health, like infant mortality? Let's continue talking about politics and health. The politics hypothesis is the hypothesis that political forces are either a predecessor of the social determinants of health or are social determinants of health themselves. By political forces, I mean the institutions and elected and non-elected state personnel, because as you may know, many of these personnel that they have a swing in health policy are not elected. They write, interpret, execute, and enforce the rules, regulations, and programs that frame the epidemiological impact of the social determinants of health. I also mean by political factors or forces, the power that relies on the government to construct identities, the belief systems, the norms that dictate human behavior, what is accepted and what is not accepted, what is socially desirable and what is not, the demographic groups that define us as social beings. And in some, the whole framework through which our social life unfolds, affecting our mental, behavioral, and emotional well-being and health. The main message is that the critical social determinants of health and the social groups in which they manifest are political constructions. When I say about the social groups that in which the social determinants of health manifest, I'm thinking about just age, race and ethnicity, gender. Just think about, for example, if you're thinking about social security for age, or immigrants. You can't define immigrants without citizenship rights, for example, or race and ethnicity. You can't think about a Native American without understanding colonialism, or Black people without understanding slavery and the Jim Crow system, which all of them are political events and factors. The other aspect of politics is that critical decisions shaping the social determinants of health happen in and are exclusive to the government. So think about, for example, just regulation of the fuel and chemical industries, which we know have a huge effect in pollution and the environment. World legislation, the minimum wage, worker unions, tax cuts, or taxing sugar sweetened beverages and tobacco, school and education, infrastructure, parks, safety, mass incarceration and the criminal justice system, Medicaid, Medicare, Social Security and the Affordable Care Act. The largest healthcare programs are totally dominated by political decisions, housing and the built environment, and many others. And we also know that all of these factors vary widely depending on the political power, party that is in power. Let's do some observations. These are the infant mortality rate trends by race for Blacks and whites. And I'm pretty sure that many of you have seen this graph before. And apparently, they are declining in a monotonic fashion, almost in a parallel fashion. The distance between the two seems almost the same throughout the trend. However, when we look a little bit closer and we detrend the time series, that is, when we draw a line that describes what is immersed in time, we start to see little fluctuations across that time trend. And it can be detected for Black infant mortality, white infant mortality, and for all races infant mortality. What is interesting is that when you mark the party of the president in this case is going to be a dark dot if it is a Democratic president, it's going to be a hollow circle if it's going to be a Republican president. You see that the fluctuations go up and down depending on who is in the presidency. You can do that with infant mortality, neonatal mortality, and post-neonatal mortality. Now, let me give you a zoom into these trends. And this is what we found. When you look at infant mortality, neonatal mortality, and post-neonatal mortality for all races and whites and for Blacks, you see a trend that is cyclical, going up and down depending on the president's party. Again, here the dark dots are Democratic presidents and the hollow dots are the Republican presidents. What you can see is that under Republican presidencies, independent from time, infant mortality rates increase relative to those of Democratic presidents. And this is true for whites and Blacks and everyone, and not only for infant mortality, but also for neonatal and post-neonatal mortality rates. Let me give you a very quick summary of these results. So net of trend, that is net of history, national and racial infant mortality rates in the United States are associated with the president's party, decreasing under Democratic and increasing under Republican presidents. There's a 3% gap between Democrats and Republicans, and it holds for national, racial, neonatal, and post-neonatal mortality rates, but we have larger effects for post-neonatal mortality. This 3% is actually very large, considering the slow pace of change in the social determinants of health compared with the 4 to 8 year cycle of presidential party regimes. In other words, just think how much it takes to improve the average educational level of the nation by 1 year. It's about 12 years. But parties on the presidency are changing about every 4 to 8 years. In proportional terms, effect size is similar for whites and Blacks, yet for Black people, the infant mortality rates are more than twice as high as white, implying substantially larger absolute effects for Blacks. In other words, the president of the party is a critical player in increasing racial infant mortality rates differences. But you may think, what about party control in state legislatures? What is that? Why is that? Well, because presidents are not the only political players. State legislatures like Congresses or the upper and the lower houses are also critical players in defining health policy. Party control, if you think about in terms of unification of the government. For example, imagining one party having the majority of representatives in state houses, while at the same time holding the presidency, for example. We know that unification of government correlates or shows largest amounts of positive agenda power, that is policy influence. That is, when the majority of members of the House and Senate in states, for example, and also at the federal level, that provides the majority party ability to control which policies are considered, which policies reach the floor for voting, for example. The agenda is enacted along party lines as well when this happens. The policy production increases compared to divided houses. It also facilitates legislative business. It shows a higher role in, for example, committee assignments, leader selections, agenda setting, procedural preferences, placements of party members in strategic agenda setting positions. So, when we run the analysis and trying to determine what is happening, we found that when you have Republican dyads, like let's say like the Republican president and Republican control state legislatures, for example, Congress, which is both the upper and the lower house, or independently, the president is a Republican and you have an upper house that is controlled by Republicans, and the same thing for lower house. This unification of government shows a huge difference in the patterns in infant mortality and also neonatal and post-neonatal mortality and racial mortality rates. I'll show you that in a minute, compared to when you have a Democratic president and a Democratic controlled state legislature. So very quickly here, you see that all of the differences are above 5%, most of them. So let me give you a quick example. Infant mortality rates between 1969 and 2014 were about 7.2% higher when the president and the Congress were controlled by Republicans compared to when presidents were Democratic and the state legislature were controlled by the Democratic Party as well. For neonatal mortality is 5.3%. And when you look at post-neonatal mortality, it's almost 10%, 9.6 percentage points. Very quickly, we did the analysis also for these dyads of unification of government by party. And what we found is a persistent and consistent, very large differences between whites and blacks. Don't get me wrong. Everyone is doing worse under Republican presidents and state legislatures. But blacks' infant mortality rates are doing even worse. Let me try to summarize some of the results from this study. Additive effects of Republican presidents and Republican-controlled state legislatures may be the most important factor affecting infant mortality rates and racial disparities in infant mortality rates. The effect is about 5 times the effect that we have discovered in the literature for education, for example. Net of trend administration under a president and a state legislature Republican dyads were characterized by infant mortality rates, neonatal mortality rates, and post-neonatal mortality rates that were about 6%, 4%, and 9% respectively higher than under Democratic presidents and state legislature dyads. These additive effects on post-neonatal effect infant mortality rates are twice as high as on neonatal mortality rates. But we kind of know why this might be the case. Neonatal effects largely reflect the health of mothers, something which reflects cumulative effects. Changes in the social and economic environment, including access and quality of healthcare, has more potential to have relatively quick effects on post-neonatal mortality effects. What is happening is that, in other words, we kind of know that neonatal mortality is more related to biology. And so this might be a cumulative effect. And what we're doing here in this analysis is disentangling the annual effect of having a Republican diet versus a Democratic diet. So this kind of requires a faster effect, which can be more easily detected in post-neonatal mortality. And that's what we're detecting. Effects on Black infant mortality rates are at least 25% higher than on white infant mortality rates. Net of trend, again, net of history, administrations under presidents and state legislative Republican diets were characterized by white and Black infant mortality rates that were about 7% and 9% respectively higher than under Democratic presidents and state legislature diets. But all of this analysis happened after the 1960s. So most of our time series is starting in 1965 or so. So we wanted to run another test with a student of mine. And we say, okay, if it is politics, why don't we look to a particular period of time in which we know the huge polarization between the parties, that is, the huge agendas and policies got totally different between Republicans and Democrats, really exacerbated. And that is the political realignment in the 1960s. So in the election of 1964, the Democratic Party officially abandoned its protectionism of the Jim Crow system in the South. So to remind you why this might be a very interesting test to do is because in the past, during the 20th century, Democrats were way more socially conservative than Republicans. Now, after the political realignment, this changed when the Democratic Party embraced the civil rights movement agenda. In the meantime, during the political realignment, the Republican Party embraced an agenda aligned with economic conservatism, neoliberal policies, for example, and not only at the macroeconomic level, but also for health policy and healthcare. We know that during this period, they started to strategically use racial stereotypes for electoral and policy support purposes, especially since the time of the Southern strategy. The literature also shows that the Republican Party prioritized reducing government involvement, that is small government, not subsidizing healthcare, and ranking the reduction of costs over healthcare access. And we kind of know also that the Republican Party ever since infused fiscal deficits via tax cuts and war spending, affecting the expansion of healthcare coverage and services. So before the political realignment, things were shift. They were different compared to how they are now. Democrats were way more socially conservative, and now they are more socially liberal. And the roles played differently. So when we wanted to see, okay, so we should be seeing the role backwards, before to after. And that's what we find. When we look at the infant mortality rates, for example, for everyone, which is the left panel at the top, you see that Democrats were doing way higher compared to Republicans. But after the political realignment, now Democrats have a way lower infant mortality rates compared to Republican presidents in infant mortality for everyone. And this happens also for neonatal and post-neonatal mortality rates, as well as for whites and Blacks. You can see also that when you compare whites and Blacks, the effects are a little bit larger for Blacks. Now, another example is, can we see another example in political history for which we have data that we could use to, well, understand these patterns a little bit better? The Reagan and Bush administrations are widely known as the neoliberal era in the United States, not only in the United States, also in England and other parts of the world. But here in the United States, we can use the Reagan and Bush administrations as good proxies for neoliberal agendas. Here we have the life expectancy gap for males by race between 1968 and 2005, just as an illustration. What you can see is an almost linear, uninterrupted trend of increasing life expectancy for white males. But that is not the case for Black males. You see, there is an abrupt interruption precisely during the Reagan and Bush administrations. In other words, it was a huge increase in life expectancy for Black males, and then it got interrupted when Ronald Reagan got into power. And this is, when you look at the life expectancy gap, you can see how it exacerbated precisely during the Reagan and Bush administrations. And Why is this important? Well, because if you look at then excess Black mortality, that is the number of Black people that should not have died if they had the mortality rates of their similar whites, then this is what happens. The total Black excess deaths exacerbated dramatically during the Reagan and Bush administrations. But more interesting is that when we look in more detail, we notice that it was not everyone. It was mostly between the ages of 0 to 54 years of age in the population. And it happens for both males and females, although for Black males, the effect was actually larger, which you can notice here because the scale of the second y-axis to your right is much larger than the one to the left. If this was the case of federal level neoliberal policy agenda, we should be able to observe that this is not a particular case of specific states. And that's exactly what we see. For the 32 states plus Washington, D.C., for which we have reliable data on Black mortality and a Black population large enough to estimate reliable mortality rates by age and gender, we find that the pattern is the same across all 32 states and Washington, D.C. So this is signaling that it was at the federal level that was something going on. We estimated the number of Black people that should not have died. And just during that period, due to Reagan and Bush administration's policies, there were more than 600,000 Black people that should not have died. But something more interesting came to light. Had the Black-white mortality gap trajectory established by the 1970s continued, mortality disparities between Blacks and whites would have been eliminated totally by 2004. We just lost a huge opportunity here. Now, there is another way to think about politics and health and how these two intersect. Let's talk very quickly about electoral politics and how it may relate to excess Black mortality. What you are seeing here is the age distributions of the disease in 2004, just as an example by race. What you see is that Black people are dying at higher rates throughout their lifespan. In 2004, their life expectancy was 72 years of age, and you see that the lines intersect between Blacks and whites precisely around life expectancy of Black people. What does that mean? That throughout their lifespan, on average, Black people are dying always at higher rates, and that they can catch up. You also see here that the lines get separated. That is, the gap increases in mortality between Blacks and whites, precisely between the ages of 40 to 65 years of age. Why is this important? Because when you look at the electorate, the people who actually go out and vote, the majority of them are precisely people between the ages of 40 and 66 and 65 years of age. In other words, Black people are dying in excess precisely during the age group or the age years in which they should be participating the most. That is, you are removing a huge part of their political voice and power. Not only that, if they are dying precisely during the age period in which they are supposed to be participating the most, but they are entering in the left of the age participation distribution, that is when they are young, you can see here that it's a very small fraction of the electorate is comprised by young people. So you have a turnover of the population due to mortality in which you are getting into the political participation distribution when people are participating at the lowest rate, but Black people are dying in excess precisely when they are participating at the highest rate. One more problem. It is not that if I die today, I will not be able to participate in the 2020 presidential election in a few days. It is that a person like me may also be alive in 4 years from today. So if you died in 1970, for example, it's not that you can't participate in 1972. There's a huge probability that you would survive for the next presidential election and maybe the next one and the next one. This means that the effect of excess mortality, especially among the Black community and other communities like Native Americans or Hispanics, have huge cumulative political effects. Let me give you a quick summary of the results of this study. The total number of Black cess deaths between 1970 and 2004 was about 2.7 million people. You can observe that I just have 35 years of data. I hope I had the data for 84 years in the lifetime, so I could cover the majority of a full cohort, but I only had data for 35 years. Blacks would have suffered 32% less deaths if they had experienced the mortality rates of whites. That is, one for every 3 people should not have died. Total Black votes lost in the 2004 presidential election was about 1.2 million votes. I only have 35 years of data, but that number of votes is already equal to votes lost among all races, not only Blacks, all races due to mass incarceration. What is this telling us? That excess mortality is the most powerful process thwarting and blocking the participation of the poor and Black people in particular, way higher than mass incarceration. Because Black people predominantly, and we know this, vote in favor of the Democratic Party. In other words, they don't split their tickets. We also calculated what would have happened if they had been alive and participated at their current participation rates. And what we noticed is that 11 gubernatorial elections and 7 Senate elections would have shifted from the Republican victor to the Democratic candidate. This is a huge implication for the balance of power between the parties, and more so acknowledging and knowing that their policies agendas are so different. For example, Bill Clinton would have had a Democratic Senate if these people would have been alive during Bill Clinton's administration. Let me now try to generalize some of these findings to the poor. So when we look at the excess mortality of the poor, it has a huge implication for the perpetuation of inequality. Let me explain how this works. Individuals, like anyone here in this meeting, we all participate in politics with the hopes to influence the politicians that prescribe the policies and programs that distribute the public goods and services that shape the social determinants of health. But the opportunity to participate in politics is conditional on survival. In other words, if I'm dead, I can't vote. My voice is not heard by the political system. But we know that in the United States, the haves enjoy a significant survival advantage over the have-nots. In other words, we know that the poor have a huge disadvantage in every regard, not only in health, but also in political participation compared to the non-poor. This leads to the conclusion that the same disadvantaged individuals whose increased participation with pressure for redistribution are those who die off from the available pool of participants at much higher rates than the socioeconomically advantaged individuals. That is, through the early disappearance of the poor, continuing political participation of high socioeconomic survivors helps to perpetuate inequality in the status quo. Because as time progresses, the electorate becomes more and more representative of high socioeconomic status individuals because they live longer. But we know they have very different political and social needs and health needs compared to the poor. There is something perverse about what is happening. And if you think about it, when a poor person dies, decreases poverty, what is observed about poverty. I can't see that poor person anymore. In other words, what is observable is way better than how things really are. In other words, excess mortality of the poor masks the true effects of social stratification. I know who of these people actually died 10 years into the future. Okay, when I compare those survivors and those who did not survive 10 years, the differences in 60% of their political participation differences could be explained by health alone. At baseline in 1995, those who didn't die 10 years later by 2005 were already participating at higher levels than those who died across all age groups and ACS levels. Without detrimental differences in health between survivors and non-survivors, we would observe a 30% increase in participation overall. In other words, the participation difference between the United States and the other developed democracies would disappear. Socioeconomic driven mortality masks the true sociopolitical disadvantage of deprived individuals, the poor and racial minorities, and the true detrimental sociopolitical effects of social stratification. I can't make a presentation about politics and health without talking, even if just a little bit, about COVID-19 and what is going on right now. So let me try to conclude just using the COVID-19 pandemic as a platform to conclude this presentation. I just show you that politics is central to health and that health is also central to politics. Political actors and institutions impart a simultaneous, multiplicative, powerful effect on the social determinants of health. Presidents, for example, and in state legislatures, the ideology of politicians and the parties and policy agendas they promote represent the most powerful component of health policymaking and execution. I think that what we have observed during the pandemic is just the continuation of the politics generated pre-existing big and many times growing racial and socioeconomic disparities in health. The COVID-19 pandemic, you can think of it as a global experiment, really as an experiment, because the biophysical process of contagion, it doesn't discriminate. So you can think of it as an exogenous shock. But what is most interesting is that this process, which is non-discriminatory, brings to light pre-existing, non-randomly distributed sociopolitical inequities in the population in the form of transference, severity of COVID-19, who dies and who don't. In the US, sociopolitical inequalities are shown to be critical underlying reasons why the pandemic manifests different effects across sociodemographic groups. Existing legislation, governmental policies and programs, and institutional dynamics, for example, the parties, are powerful forces that distribute the public goods and services that ultimately shape the social determinants of health. In other words, the pre-existing distribution of the social determinants of health It is what is determining COVID-19 transmission and severity. And this has been widely observed, not only in the United States, but around the globe. As governments, talking in international terms, as governments have enacted their COVID-19 pandemic responses, the distribution of life-saving resources has followed the same established sociopolitical paths through which their social hierarchies were created. Very briefly, let's look at some of the things that have happened that are related to politics here in the United States during the pandemic. We know that political actors have exacerbated conditions that put vulnerable communities at higher infection risk. We know that political actors have fueled social unrest. We have observed unequally distributing the resources of the CARES Act in favor of corporations, the weakening of public health institutions like the CDC, being non-ethical, like rewriting CDC reports, which is happening right now. The slandering evidence-based strategies needed to contain the spread of COVID-19, undermining the seriousness of the pandemic, showing ambiguity about wearing a face mask or maintaining physical distance, etc., etc., etc. Under these circumstances, SARS-CoV-2 is not the only underlying cause of the pandemic crisis in the US. Politics is as well. Let me give you some final lessons to finish the presentation. The pandemic has showed how much the economy and public health rely on government decisions. It also exposed how the economy and public health are intertwined, especially in this false dichotomy that controlling the virus and saving the economy are mutually exclusive. We have also seen through the pandemic a powerful inertia in the economy and public health. Instead of focusing on adaptation, all efforts have been deployed to maintain the economy and the healthcare system as they are, even though we already see the detrimental effects of the pre-existing conditions in the economy and our healthcare system. The causes of the crisis have been ignored. We focus only on the consequences. And after the pandemic, we will still have the underlying racism, classism, and inequality that we have had even before the pandemic. We lost again a huge opportunity. Something that is critical is that the scientific community lacks political and community power. We need to change that. Education is not enough. We need a scientifically educated community, but that will take a very long time. No change in health will come without changing politics. In my opinion, the most important question of the 21st century, no matter your discipline and your background, is how can we change politics? Thank you very much.
Thank you very much, Dr. Rodriguez, for an amazing presentation. I'm going to go ahead and read questions. And for those of you, if you have any questions, please feel free, questions, comments, please use the chat box. Let's see. Your presentation is extremely important and uniquely sets as far as I know, a clear new paradigm of politics and inequality and very damaging consequences. That was a comment from Dean Balcazar. I couldn't agree more. Comment. And the next question, what is your opinion of how we address social determinants by time and space and factors at this time? Are we missing the key to opening a new agenda for social justice and inequalities? Can we continue to set the stage in the form of social determinants, missing the political system?
I just show you how politics relates to the social determinants of health. I just also show you not only how politics shape the social determinants of health, but also how health shape politics, and how Racial and socioeconomic disparities in health are at the core of inequalities in democratic systems, including the United States. I do think that the most important thing that we need to take into account is that what I just showed you, we need to participate in politics. That's the first thing that we need to do, but we have many other political problems. Public health, epidemiology, and the medical sciences, I think, have been among the most successful disciplines in the last 2 to 3 decades. We actually know what to do to improve public health. Just think about the infrastructure, the environment, etc. So the question is not what to do. We know what to do. The problem is that politics is not allowing for the progress of the social determinants of health. Again, what we need to change is politics. But at the same time, we have a huge problem of representation in the system. We have, and this is what the literature is showing, not only here, but internationally as well, we have that left parties are not representing their constituencies. So for the first time, like central parties like the Democratic Party, they have very clearly identified what are the social programs. They are actually elaborating on the scientific community on how to understand and communicate effectively what are the problems. But don't think for a moment that what I show you is because Republicans are terrible and Democrats are saints. No, they are not. Democrats are not representing the community. Health under Democratic presidencies and state legislatures, they outperform Republicans by far, but it is because Republicans are doing really, really bad in the social determinants of health. Democrats in reality are not representing quite well what we could do for politics. If you just look at a trend on income and wealth inequality, it has a non-stop, not interrupted trend since the 1970s, like a rocket. And since the 1970s, we would have had many types of presidencies and administrations. So what is this telling us? Both parties are compromised with corporations and big wealth, and they are not representing the average citizen. There are also many studies that show that when we measure how political elites think and how their ideologies shape the policies they vote for or that they propose on the floor, they do not reflect the people that actually voted for them. So we have, again, a huge problem in politics. And this is the other thing, the thing that I just showed you. As far as we continue having these huge inequalities in mortality, in which 2.8 million people die every year because, okay, we have a large population, but the great majority of them tend to follow the patterns of racial and socioeconomic disparities in social determinants of health. What is happening? We are removing from the world those people who actually can vote and try to increase the representation of the system. That is a huge problem. So to answer the question more explicitly, the environment, we know that the environment is crucial. The environmental and ecosystems that have been changing have facilitated the microbial and viral mutations that we are seeing right now. So COVID-19 is just the first of many pandemics that will come, but we are not changing or adapting our systems. Why is that? Politics is the reason. So if you think, oh, institutional racism is the cause, politics is the cause. Or where do you think that this racism is being institutionalized? In governmental institutions, in the law, in the governmental apparatus. If you think, oh, classism and socioeconomic inequality is the cause, politics is the cause. Who is distributing the public goods and services that determine the standards of life and the quality of life of individuals? Government is doing that. So the first thing as a community in health is to start thinking that no matter what you do, you need to think in political terms.
Thank you. So I wanted to, Dr. Young wanted to share, quote, medicine is a social science and politics is nothing more than medicine on a large scale, from Rudolf Virchow. Virchow believed that the social basis of disease, poverty, ignorance, and oppression needed a political remedy, just as the biological factors needed a strictly biomedical one. A question from Anjanette. Do you want to go ahead and ask your question, Anjanette? Perhaps maybe you can ask one of your questions to allow time for others.
Okay, sure. Thank you. It was an excellent presentation. And thank you, Mr. Lopez, for inviting me to participate. I actually have several questions, but let me see if I can just narrow it to the most important. I would like to say it saddens me to hear these numbers and the numbers that I have been hearing. One death is way too many, yet alone the numbers that we're faced with as Blacks here in the United States. So I guess if I had to narrow it, I would ask you, how and what can we do as communities and as cities and states to implement change? It looks as though as long as we have governments, politics at the forefront and in the driver's seat, we are seeing little to no change. So what does that look like, and how can we start to, as a people, make change outside of government and politics so that these inadequacies and this unfairness and so that we can start to see things more equitable for everyone.
Thank you, Annette, so much for your question. As I mentioned, that might be the most difficult question that you can ask to anyone, because we don't know. We may have some ideas, and this is actually a question that has been flowing in the minds since Aristotle and Plato, and we still don't know how to do that. But we have seen many changes in the world, and we do have evidence-based ways of thinking about politics and health. Two main ideas that I think that are not widely discussed. Let me give you the first one. The first one is related to nonprofit organizations and advocate groups. These are organizations that already have funding. They do have a supporting and very active constituency. But there are many advocates groups for poverty, many nonprofits against poverty. And we're right here in the most wealthy nation in human history with a poverty rate about 13%. And not only that, the conjunctions with race and many other factors that exacerbate social injustice. So the question is, what do we do? Aren't these people actually doing what they say are supposed to be doing? Because we can't ignore that there are billions of dollars invested through these NGOs and groups. But let me tell you, why is that? The reason is, again, politics. They are isolated from the political system. They are working in isolation. But not only that, when they finally have the resources, they understand their problem and they know how to solve their problem, what happens is that once they reach out to the political system, again, they are not represented. So, first solution, I am telling the nonprofit organization community and advocate groups, stop doing that. Do it yourself. You gotta do it yourself. If you think about the environment and you think that we need to promote more, let's say, no more plastic bags, but a different bag, do it yourself. Don't ask anymore. Go and produce the bags that you think are gonna be useful for the environment. If we're using masks, I'm pretty sure that you have already seen, the ocean is packed with these masks and they are changing everything again. So where are these healthy for the environment masks? There are many organizations trying to promote, oh, we should do this or that. Great, but stop asking and do it yourself. Use your money, use your expertise, use your constituency and experts to produce the mass that you want us to do. And maybe use that as an additional funding source. That said, so no more asking, let's do it yourself. But again, that will have a limited effect if we can't use that muscle to influence politics. And that takes me to the second point, the one that I mentioned. The scientific community doesn't have a political muscle. We don't have political power. How is it possible that in the midst of a pandemic, we still have a huge amount of people in the United States that think that using masks or that prudent social distancing or physical distancing is not important? So what's happening? We have the scientists, we have the research, we can articulate very well what's going on and how it actually helps. We understand everything. We know what to do. But what is happening? Politics is in the middle of the way. And it is not like this little thing in the middle of the way. It's like a train in the middle of the way. So we need to organize the scientific community. And we need to organize it in the way that has been successful in the past and in many nations with other type of organization. For example, the labor unions. Mm-hmm. They have shown in the Nordic nations to be, which are the most developed and richest nations in the world, to be very effective. And they are no mutually exclusive from the health of the economy, for example. We also know what had happened when we have very strong labor unions. I know there's corruption, all of these other factors, but we can use examples. We can also use how communities have organized. Look at, for example, the gay community in politics. They are quite powerful. Look at, for example, the Jewish community in politics. They are quite powerful. They are very well organized. Why can't we all jump in the same bus? We are all sharing the political destiny of oppression. But as far as politics intervene and we look more different from each other, that is what is blocking the possibility of us working as a unified community against inequality and promoting social welfare. So we need to organize the scientific community, not only for the purposes of our participation, because it is also very unfortunate that, for example, PhDs and doctors, we are a minority in the community. We need to promote a scientifically educated community. We need to articulate the problems, but we need not only, as we organize, we need to start putting people from our own community in political positions, and we vote for them. It's just like a first step, so we start to educate the communities and the policy choices on the floor. We can't continue writing papers that we're going to be just citing among ourselves. We need to be able not only to reach out to the community, but we need to be able to have an effect on the floor when the policies are decided. We can't do that the way we're doing it. That's why we're thinking, that's what we are observing. That's why things are going on in the direction that we observe. Mm-hmm. So I think that for now, there is no silver bullet for this problem. It's actually a problem. I mean, when you read Rousseau and many of these political theories, is the problem that has been there without a solution. And probably there's no concrete solution, but we need to move forward. Those are the two things that I think have not been widely discussed and that they need more conversation and debate.
Thank you very much, Dr. Rodriguez, for, again, an insightful presentation. We definitely want to continue the discussion and would love to invite you back to talk with, just to have further discussion and even potential collaborations as well. We didn't get a chance to get to all of the questions and comments, but we're going to be sure to share with you. And for those of you joining, we are recording this lecture, so we will provide the link to the recording once that is available. So again, on behalf of the Urban Health Institute, thank you all for joining us for our Haynes this month. And again, thank you very much, Dr. Rodriguez. We really appreciate your time and your commitment and your
Thank you
work.
so much for the invitation.
Thank you. Thanks, everyone. Take
Bye.
care. Thank you. Thanks to the UHI team also for helping to ensure that this was a success. Thank you.